Ορκίζομαι από τον Απόλλωνα, τον θεραπευτή, τον αστικλείο.
Ancient physicians swore by their gods to uphold specific ethical standards. These words were written by Hippocrates, a Greek physician regarded as the father of modern medicine. Almost 2.5 millennia later, physicians still swear by a modernized version of these words. It is known as the Hippocratic Oath.
All set?
Sure am.
Raj, in your opinion, is there a crisis in access to pain relief medicine?
Oh, yes. Oh, yes. It's a shame, really. It's not a question of resources, really. Pain medication, basic pain medication can be very inexpensive. It's there. It's lying there. It's just not getting to the man who needs it. We really have no reliable statistics. We estimate that at least 1.5 million people in the country are suffering from cancer pain at any one point of time. That's only cancer, mind you. We have no statistics at all about other very severely painful conditions. A very uneducated guess would be something like 5 million. So there is definitely a problem.
Over 1.25 billion people live in India. Almost 225 million Indians live below the poverty line. They survive on less than $2 American a day. For every 1,700 people, there is one doctor. This is the story of one doctor.
I swear to fulfill, to the best of my ability and judgment, this covenant. I will respect the hard-won scientific gains of those physicians in whose steps I walk, and gladly share such knowledge as is mine with those who are to follow. I will apply, for the benefit of the sick, all measures which are required, avoiding those twin traps of over-treatment and therapeutic nihilism. Most especially must I tread with care in matters of life and death. If it is given to me to save a life, all thanks. But it may also be within my power to take a life. This awesome responsibility must be faced with great humbleness and awareness of my own frailty. Above all, I must not play at God. I will remember that I remain a member of society with special obligations to all my fellow human beings, those sound of mind and body as well as the improved. May I always act so as to preserve the finest traditions of my calling. And may I long experience the joy of healing those who seek my help. So this whole flow forms the palliative care unit.
It is health that is the real wealth, not pieces of gold and silver.
Over here, we have the outpatient clinic. Patients coming to our outpatient clinic are very often very sick, and therefore we have these patient bays so that even outpatients can stay here. All treatment in this unit is completely free for 82% of our patients. Anybody who is classed as poor or very poor, they're all treatment free, including free drugs for palliative care, because most of them would have been so reduced by disease and its treatment that they would have no resources left, and many of them would be in debt, they would have lost their homes, so we give it free. What is palliative care? You can either go by that World Health Organization's definition, which says that it is treatment aimed at improving quality of life of the patient and the family by assessing the physical, psychological, social, and spiritual domains of suffering, and trying to prevent and treat as much of that suffering as possible. That's a long sentence. But the point is, it's about quality of life, and it is about preventing and treating suffering. It's a huge privilege that comes to a tiny minority of human beings to influence others as much as a doctor or nurse can. We are dealing with them at the most vulnerable time of their lives, and we have almost the power of life and death over them. When I say life or death, I also mean not only the body, but also the mind. It's easy to destroy somebody with a few words. It's also easy to lend a hand and lift somebody up from the depths with a few words and a touch that say, I care for you. That empathy, to put ourselves in those people's shoes and try to understand what they must be going through and helping them to, if not bloom, at least to live, and when the time comes to die, with dignity.
Strength does not come from physical capacity. It comes from an indomitable will.
I was born soon after India became independent. I grew up in a time of excitement where the country was slowly recovering from great poverty after the British rule. I come from the state of Kerala in India. Kerala is a tiny state in the southwest of India. Kerala has only 1% of India's landmass but 3% of India's population. It's a thickly populated state. I did grow up amidst a lot of pain and suffering. On the positive side, we children grew up accepting pain and suffering and death as part of life. When somebody died in the family, we would still be with the dead bodies. We would see the cremation. It was all a part of life. But it was also sad that even though things seemed to be improving in many ways, that did not happen about pain and suffering. Then and now, pain and suffering in the society remains largely unalleviated. The whole village at one time would come to this lake to bathe. I remember our whole family coming here to bathe. The older women bring the children here, bathing as first, putting them to play out there, and then bathing themselves. As a child, I did not have a lot of social skills. I was an average student. I would never be the first in class. And then as a schoolboy, I read Mahatma Gandhi's My Experiments with Truth, which I think had a huge influence on me. What attracted me most in Mahatma Gandhi's life was his courage of conviction. Even under intense pressure, he would not give in just to be popular. He would insist on doing the right thing, even if it was not very expedient. I remember one quote from him. I'll try to quote it, but it went something like this. Recall the face of the poorest and humblest man whom you have seen, and ask yourself whether the step that you are going to take is of any use to him. Later practicing medicine, I have endeavored to bear that in my mind, because there is a marginalized section of the society, a large chunk of the society about whom nobody seems to bother about, and he reminds me not to forget them.
Recall the face of the poorest and weakest man you have seen, and ask yourself if this step you contemplate is going to be of any use to him.
Doctors have to care. I make that statement deliberately. The way medical science is progressing, there is a tendency for doctors to be contained as medical technologies, human machines diagnosing diseases and attacking the diseases, whether or not the patient gets emotionally and socially destroyed in the process. But any human being can care for somebody who is suffering from a disease. In most of the developing world, if somebody is bedbound, it's the family who cares for him or her. The families care anyway, without any training, without knowing what to do. So doctors have to learn not only to cure, but also to care. This is a 50-year-old lady. This is the family tree, or the genogram as we call it. So there is a patient whose husband died soon after their marriage. She had a daughter who is also no more. She lives with the 85-year-old father, who is perhaps one of the most healthy people in the family. She also lives with and looks after her nephew. He's a deaf mute, but he also has a psychological problem. And she is the sole carer for her 3 brothers. All of them have a congenital abnormality, something that they were born with. She also yearns for the family. She gets up at 4 o'clock in the morning, washes the 3 men, cooks breakfast. Then she takes a bus to the market, buys some vegetables and a dry fish, brings it to the locality under a tree where she sets up shop. And in the evening she comes back, cooks dinner, looks after the men, feeds them. That's her routine. So now that she was having a severe back pain, she was laid up. There was practically no one to look after the whole family. There was no money coming in. They were in desperate straits.
Man becomes great exactly in the degree in which he works for the welfare of his fellow man.
This house was renovated about 10 years back. Prior to that, there was a small, humble home here. That was where I was born, back in the year 1947. My father, my mother, and my maternal grandparents lived in this house. I was passionate about knowing more. I was fascinated by Shakespeare and generally literature was what I wanted to study. But my father said, "You have got admission to the medical school. Come along, we are going." And I went. I did not really want to, but I have no regrets. I am glad he made me go into medical school. I did not protest. And that has been a huge privilege. When I come back here, I mostly think about my grandparents and my parents. I was with them, with each one of them when they died. And my grandfather was the first to go. That was before my palliative care days. And I do remember a lot of suffering at that time. But my grandmother and my parents died after I came into palliative care. And I believe that helped them quite a bit because I could give them care here in their homes and I could allow them to go without a lot of suffering. Hello. Ajite? Ani? Ani എന്തൊന്നും പറഞ്ഞില്ല. Ani വേണങ്ങിയാ? So when we examined her, we found that she had pain that goes down the legs from her back, which is commonly associated with a disc prolapse, which causes pressure on the nerves and causes pain. And we treated that with epidural injections, in addition to painkillers. With that, she got relief and she started going back to work. Now, some 30 years back, it would have been treated the way we do, based on just an examination. But today, most doctors would not give the proper treatment without doing an MRI scan, which rules out treatment for quite a number of people if they cannot afford an MRI scan. Unfortunately, one very, very real development, especially in the last 35 or 40 years, that's the transformation of health service to healthcare industry. In steel and in concrete, we have built bigger and bigger hospitals, fortresses with armed guards keeping patients out. Modern, brave new world has evolved it into a truly successful industry. Now, growth of healthcare as an industry has certainly improved our ability to conquer more and more diseases. But somewhere medical practice lost a bit of the heart. It's all brain now. What has happened is the process of diagnosis, the technology that is evolved in UK, USA or Australia, in my country, and in 80% of the globe, that's the developing world. Even the process of diagnosis, the imaging, the MRI scans and everything will financially destroy many families. That's the reality. And then comes the treatment. What the industry wants is not only cure the disease, it's also profit.
You must not lose faith in humanity. Humanity is an ocean. If a few drops of the ocean are dirty, the ocean does not become dirty.
We can help him to live with dignity if we understand a few things. So as I said, we cannot solve all his problems. He has problems. We cannot solve all of them, but many of them can be solved. So we are going to talk a bit about pain management. But I would like to start by asking you a question. What is pain? As a medical student, I was confused about what the role of a doctor is. Some of you who are hearing me today, you would have possibly taken a Hippocratic oath. Some of you would have taken it seriously. For some like me, it might have been just a ritual. I was not touched by it because it seemed too idealistic, too impractical. I say that because that was so contradictory to what I saw being practiced around me. Did not really seem in tune with the Hippocratic oath. So somewhere I thought it was something to be shelved. I did not see a lot of compassion around me. And I learned nothing about proper pain assessment or management. Oh, we did learn some pharmacology of painkillers, but as a dead subject, not something that was actually practiced. ശ്വാസമുട്ടിന്റെ കാര്യമല്ല, ക്യാൻസർ ഇവിടെ അല്ലേ, അത് കാരണം എന്തെങ്കിലും വിഷമം ഉണ്ടാകുന്നുണ്ടോ ഇപ്പോൾ? So I did not learn how suffering is to be treated, how to help a dying person, for example. One of my earliest memories in my first year of medical studies, a painful memory that shaped my career, was that I had a cousin who lived about 100 meters away. At night, when I sit up and try to study Gray's Anatomy, I would hear screams coming from his home. It would go on and on, never stopping. He had cancer. The family asked me, could I help? There was nothing I could do to help. I did not do anything to help him. But not only that, looking back, I realized that I stopped visiting him. It must have been sheer helplessness. I was giving myself excuses for running away. That, as a student and as a doctor, I continued to see all the time. People were in pain and suffering. And what I saw around me was not a very humane kind of medical practice. അജിത്തിന് എന്ത് പറ്റിയത് കാലില്?
സഹായിക്കണ അജിത്ത് ഇന്നലെ ഞാൻ ആ നോത്തിട്ടിട്ടില്ല, കിടന്നിട്ടുമില്ല. അജിത്തിന്റെ കാലിന് ഏതാണ്ട് ഈ സൈഡിൽ ഇങ്ങനെ ഒരു കായ്പായിരുന്നു. ഇവിടെ ഇങ്ങനെ കായ്പായിരുന്നു.
ഞാൻ കൂടെ ഇരിക്കട്ടെ അവിടെ.
അത് കൊണ്ട് പഴുത്ത് ഇങ്ങനെ വീണ്ടും അയക്ക് പഴുപ്പുമായിട്ട് വന്നുകൊണ്ടിരുന്നു. ഇന്നലെ കൊണ്ടുപോയി. ഇവിടെ ഇത്രയും ഉണ്ടായിരുന്നു. കീറി വിളി, ഭയങ്കര വിളി വിളിച്ചു. ഇന്നലെ വേദന ഉറങ്ങിയില്ല,
അല്ലേ എന്നിട്ട് പിന്നെ വേദനയ്ക്ക് മരുന്നൊന്നും തന്നില്ല?
ആ ഗുളികയ്ക്ക് കുറച്ച് തന്നെ എടുത്തായിരുന്നു.
For 80% of the global population have no effective socialized medicine. They have no effective insurance system to support them. This means that the prescription that I write may have the power to take away some of their problems, but it also has the power to deprive the family of their next meal.
അത് 5 ദിവസത്തേക്ക് എടുക്കാൻ പറഞ്ഞു. അപ്പോൾ പൈസ കാണിക്കുമ്പോൾ എന്താണ് വില കൂടിയ ഗുളിക 150. ഞാൻ പിന്നെ ഇന്നലെ ഒരു പ്രാവശ്യം കൊടുത്ത് ഇന്ന് 2 പ്രാവശ്യം കൊടുക്കാനേ എടുത്തുള്ളൂ. അത് രാവിലെ കൊടുത്തിനി വൈകിട്ട് കൊടുക്കാൻ. ഇത്ര എടുത്തുള്ളൂ, വേറെ എടുത്തില്ല.
Poverty is the worst form of violence.
In the developing world, the profit-making industry goes unchecked. The same medicine that's available for a few hundred rupees is also sold by another company in India at about 50 times that cost. And the doctors would prescribe the more expensive medicine, more expensive formulation. That kind of practice, which destroys families totally, is going on unchecked.
ഡോക്ടർ റൂമിൽ പോയി കണ്ട് പൈസ കൊടുത്ത്
എത്ര കൊടുക്കണം?
ഇത് രാവിലെ
ഇതിന്റെ വിലയല്ല, ഡോക്ടർക്ക് എത്ര കൊടുക്കും?
100 വാങ്ങി.
What I find very painful to accept, that doctors thoughtlessly write prescriptions for very expensive medicines when there are very inexpensive alternatives, simply because the medical representatives push them, and in your mind the expensive medicine is what is coming on the top of the list. നമുക്ക് അജിത്തിന് വേദനയ്ക്ക് വേറെ ഗുളിക ഇത്രയും വില ഇല്ലാതെ ഇതേ ഫലമുള്ള ഗുളിക കിട്ടും കേട്ടോ.
തന്നില്ല. ഞാൻ അങ്ങനെ ഈ വർഷം കാലേജൊന്നും ഇലക്ഷനൊന്നും പോയില്ല. അങ്ങനെ വരാനായിട്ട് താഴോട്ട് ഇങ്ങനെ ഒരു ഷെട്ട് കെട്ടിയിട്ട്
I've just put on some local anesthetic onto the surface because before we proceed with the rest of the dressing, I'd like to give him some pain relief. Unfortunately, people in pain and suffering are very vulnerable. They have no ability to get up and fight. So, this is a very, very one-sided war. But will we, as a cultured society, continue to refuse to see that kind of suffering? Will we allow the greed of some nameless, faceless entities just to keep on destroying people in the developing world? I see that kind of destruction happening day after day in our society. When we first came here in 2008, there were these 3 helpless men. We found that they were sitting on the floor. So we got these paddings on the wall and on the floor so that they could sit with some comfort. ഇപ്പോഴ് ഗോമതിക്കും കുടുംബത്തിനും എന്താകുമായിരുന്നു, ഇപ്പോഴത്തെ സ്ഥിതി എന്തായിരിക്കുമായിരുന്നു എന്ന് ആലോചിച്ചാൽ പറയാൻ പറ്റുമോന്നാ ചോദിക്കുന്നത്. എങ്ങനെയായിരുന്നേനെ, എന്തായിരുന്നേനെ
ആത്മഹത്യ ചെയ്യേണ്ടായിരുന്നു.
ഇപ്പൊ എവർക്കും വല്ലതും കൊടുക്കാന്നൊക്കെ ആലോചന
പോയിട്ടുണ്ട്. അമ്മയും തയ്യാറായിട്ടുണ്ട് അതിന് നമുക്കൊക്കെ തരാൻ.
അമ്മ ഉള്ളപ്പോഴും
4 വർഷം അപ്പൊ ഇദ്ദേഹം വഴിപ്പെടുകൂല.
ആര്?
അനില്.
ബാക്കി എല്ലാരും സമ്മതിച്ചോ?
എല്ലാരും സമ്മതിച്ചിട്ടുണ്ട്. പിന്നെ ഇവൻ മാത്രം അതിന് വഴിപ്പെടൂലായിരുന്നു. അങ്ങനെയാണ് അമ്മയ്ക്ക് പിന്നെ വാത്സല്യം കൂടുതൽ ഇദ്ദേഹത്തിനോടാണ്. പിന്നെ അമ്മ അതൊക്കെ അങ്ങ് മാറ്റി.
So when she mentioned suicide, she said something that was very difficult to take in, that they had discussed it, but the youngest would not accept it, which prevented the family from committing mass suicide. Healthcare industry will get transformed. It has to happen. And because you and I today are healthy enough to walk on our 2 feet and to raise our voice and speak, I believe we have the responsibility to give voice to those who are voiceless today.
Where there is love, there is life.
I fell in love with Chandrika when we were interns, when we had just completed medical studies. And we were posted together at a primary health center by the seaside. Very romantic atmosphere. Well, I was quite an impressive figure then, weighing about 10 kilos less than now. And especially threatening to disappear with the sea breeze. We belong to the same religion, Hindu, but we belong to different castes. That was and still is an issue here. Neither family wanted us to get married. It was difficult, but eventually her family came round first. Eventually, very, very reluctantly, my family also. They had no choice. Then we got married without any celebration. We got married in front of the church. Temple. Temple. We got married in front of the temple. My parents had come, and the distress was so bad that my mother stood on the door of the temple and cried all through the ceremony. My father was very grim. And I don't think the ceremony itself was a very cheerful one. But thereafter we had a very happy time together. We had 2 sons. They are both engineers, both married to engineers. They have a child each. It was serendipity that took me to anesthesiology, because one component of anesthesiology is pain management. In all our textbooks, there would be that one chapter on pain. But again, it was not practiced. It was not examinable. We did not have to study it. But possibly because the memory of my cousin's screams influenced me, I started looking up pain management. I tried to do some things, but as an assistant in a department, I did not have the freedom to manage pain. But at the age of 38 or 39, when eventually I became a head of department, I had the ability to do some things. And in my spare time, I started treating people with pain, mostly with nerve blocks. And once I gave a nerve block for a 42-year-old college professor with advanced cancer of the tongue. The block was very successful. The next day, he was pain-free. I was very happy. The man asked me when he should come again. I said, you don't have to come back unless there is pain. If you get pain again, then you come back. But I expect that you will be pain-free for 3 to 6 months. The man committed suicide the next day. What his cousin later told me, that till I told him, you don't have to come back, he was hoping for a cure. Nobody had discussed the prognosis with him. And the fact that I told him, you don't have to come back, indirectly conveyed to him that his condition was incurable. That experience brought home to me the point that a man with cancer is not just a container of cancer or a mass of nerves to be blocked, that they are human beings. I am not only a doctor, I am also a human being. And when I am treating this man with such suffering, I should have bothered to find out how he felt, what his fears were, what his anxieties were. Instead of that, I was concerned only with a nerve. What that professor taught me was the lesson that treatment of a person like that was important, not just treatment of the pain.
You must be the change you wish to see in the world.
I am very proud of my country, of its cultural heritage, of its atmosphere of love and bonding between human beings. I am proud of the sincerity and openness of our people. I am not so proud of the fact that we, Indians, allow 1/3 of our population to be below the international poverty line. The least I can do is not to worsen the situation, but the medical system is today feeding that poverty even in the relatively affluent state of Kerala in India. A study by a reputed organization, Center for Development Studies in Trivandrum, found that in rural Kerala, 1/3, almost 1/3 of all poverty was caused by disease and its treatment. We have to remember this, that even if we cannot solve it, we can at least try to avoid it. We can certainly try to avoid the infliction of needless treatment and needless investigations to patients. How can we justify a medical system which is today in India 80% in the private sector, which is not controlled by any national authority, which is free to do as it wants without any operational guidelines or standard operating procedures, without any monitoring system?
A nation's culture resides in the hearts and in the soul of its people.
In the 1980s, I had bought a book out of a catalog during one of those rare times when I had some money with me. I thought it would tell me about a lot of nerve blocks, but it had nothing about nerve blocks. I was disappointed. I stuck it in a shelf. Many years later, when my nerve block was successful and gave pain relief, and still a college professor committed suicide that night, I chanced upon that book that I have shoved into my shelf. I took it back. I started reading it, and that's how Twycross came into our lives. And I came across this business of palliative care. And then I heard about a palliative care workshop held in Trivandrum by one British nurse by name Gilly Byrne. From the 1980s, she used to wander all over India and talk about palliative care to anyone who would listen. After the workshop, I went to her and talked to her that I was doing this little bit of work in Calicut. Would you like to come and see it? I thought she would say, okay, maybe next year. But she said, how about day after tomorrow? And she came and saw what we were doing with patients, combining nerve blocks with medicines and a little bit of psychological support. And about 1 hour after she came, she asked, would you like to go for a workshop in Oxford this coming September? I jumped at the chance. She found the money to take 6 Indians to go for a workshop in Oxford for 10 weeks, a course run by Dr. Toycross. And that was where I learned scientific palliative care. In the early days, when I was treating patients with pain, 2 of my colleagues were very much interested and would come and watch and help. One was Dr. Molly John, who was associate professor, and another was Dr. Suresh Kumar, who was a postgraduate student in my department. And that's how we started our work in 1993. We developed a non-government organization to support our activities. This was the Pain and Palliative Care Society, which was registered under Indian Charitable Societies Act. And in 1994, we rolled out a palliative care program.
A small body of determined spirits, fired by an unquenchable faith in their mission, can alter the course of history.
This is the house, the government quarters, where I stayed with my family for 17 years, from 1986 to 2002. Very often I feel this as sort of house I am associated with more than my own house in Trivandrum. This is Ashok Kumar. He used to run a press. We came across each other when we wanted a newsletter printed. He had his own experiences with disease among friends and families. So we used to share experiences, and actually very often Ashok, Suresh and I would sit in the drawing room here, and that's where the planning for the Pain and Palliative Care Society occurred. Initially, it was just I functioning as a doctor, aided by 2 wonderful women, Meena and Lizzie, who are still in Calicut. They were housewives with no medical background. They would be there talking to the patients and families, building a relationship. Actually, we all learned palliative care together. And one of the things that Ashok taught me was that I have a limitation of my degree and my view as a doctor. To quote a typical example, I designed a brochure for Pain and Palliative Care Society, and in the bottom was a banner, "Victims of cancer need your help, lend a hand." We thought it was fantastic. It was Ashokan who said, don't call them victims. They're not necessarily victims. I mean, that's a stigmatizing word. And this kind of input was the key. I mean, okay, it was just a word, but it was actually a philosophy being brought in. So that was the greatest significance. Being able to think from the point of view of a human being and not the external view which a medical professional gives. During our early days of palliative care, Subair came to us. He was in agonizing pain from a cancer in his leg. He had gone through radiation. He had lost his home due to the cost of treatment. He had 4 children. He had had to send all 3 of the elder children to an orphanage because he could not afford to keep them. In addition to giving morphine and other pain-relieving drugs, we got a sponsor to provide a coffee vending machine for him, with which he started making his livelihood within the hospital. That business is still thriving. He started giving back to the Pain and Palliative Care Society a portion of his earnings. His children came back from the orphanage into the family. They started schooling. His wife herself went to a school and learned a business and started working. So when you consider the patient as a whole, not just as a vehicle containing cancer, then you look at the suffering. And if they need psychological, social, or spiritual support, you provide that along with the treatment of the disease and treatment of the symptoms. Now, this is what palliative care is about, but I truly believe that this is what healthcare as a whole should be about building lives, not about destroying lives. Generally, the public in Calicut, they were always supportive. Newspapers started writing about it. But the support from the administration and from the hospital and from colleagues was harder to come by. But I have a genuine feeling that the public forced the doctors and the government to change. And in the next 8 or 9 years, there were about 40 palliative care centers in the northern side of Kerala. In 2 years, the palliative care program attracted enough attention to become a World Health Organization's demonstration project. I believe that happened because the system of care that we created there was something that was very much suited to the cultural background of India and Kerala. It fitted in. I would think it fitted in like a glove. The system of care was low cost. People could still stay at home. So we did that so long as I was with the government service in Calicut.
The best way to find yourself is to lose yourself in the service of others.
It is tough even for me. Her whole body is in pain, but it's all unnecessary. She's not suffering from the cancer, really. She had all sorts of scans and things, but not pain medication. അപ്പോൾ നിങ്ങളിൽ ഒരാളിപ്പോൾ പോവും വണ്ടിയിലേക്ക്, ഇവിടുന്ന് ഒരാളിനെ കൂടെ കൊണ്ടുപോകും, ടാബ്ലറ്റ് കൊടുത്ത് വിടും. തൽക്കാലത്തേക്ക് മോഫിനും പെരിനാമും ഇപ്പോൾ ഇവിടെ ഉണ്ടോ? മോഫിനുണ്ട്. I am starting this quick morphine titration where oral morphine will be given. Then I suspect that, considering everything realistically, she will be at least partly relieved of the pain. Then we'll move her, hopefully tomorrow, to our institute. They are willing for admission. I would have liked to take her away immediately, but there are practical difficulties, like you know what sort of terrain we have. But also that it will be very painful for her to be moved now. അതൊന്ന് പറയുന്ന നമ്പറിൽ കേട്ടോ. അപ്പോഴത്തേക്കും കുറയും വേദന. Once I had started on this journey in the 1980s, after I had treated a few patients with pain, from that time, there has been no question of returning. There was the sea of suffering out there, and there was something I could do about it. I had the power, and not doing it would have been running away. That would have been cowardice. I couldn't do that. After starting palliative care, I learned about life. She's inviting me to sit down. She says, sit down. It was a privilege to have people share their innermost concerns with me and enable me to be part of their lives. She's saying she's much better. This is Lata Kumari, whom we saw last evening. And she looks so amazingly and so happily different. She's a bit sleepy all the time. But maybe she needs to be a bit sleepy rather than in pain. We'll play around with her morphine dose so that we can keep her as alert as possible at the same time pain-free.
Peace is its own reward.
Morphine is a painkiller which is matchless in the sense that for 2/3 of our people with cancer pain in India, there is no other medicine that can relieve their pain. It's an essential medicine. It's an essential medicine in WHO's essential medicine list. It's an essential medicine in India government's essential medicine list. It's a medicine that's made out of opium, which is produced from poppy plants. Some countries, including India and Australia, legally grow poppy under license. All the product has to be sold to the government opium and alkaloid factory. They produce opium and most of it is exported to the Western countries. So, though we grow poppy, though we produce opium and morphine, though we export it to the rest of the world, our own people are denied it. There are some reasons why this has happened. Morphine and opium have a bad reputation in the country and in the world over because it's a medicine that can be abused. And especially in its injectable form and some of its injectable formulations, it can really cause addiction. Because of the fear, in 1985, the government of India passed a draconian act, the Narcotic Drugs and Psychotropic Substances Act of India, which significantly reduced availability of morphine for people in pain. Already the situation was bad enough. It made it really bad. If we look at the morphine consumption in 1985, it was something in the order of 600 kilograms in the country. Mind you, all that was used mostly in operation theaters or emergency units for people with trauma and so on. Suppose this was 600 kilograms. And then came the NDPS Act, Narcotic Drugs and Psychotropic Substances Act of 1985. And the result was gradually pharmacies and hospitals stopped applying for morphine, stopped talking morphine, drug controllers stopped issuing licenses. So much so that by 1997, the consumption had dropped to about 37 kilograms. This kind of drop. Mind you, if everybody who needed morphine for pain relief got the morphine, India with its current population would need something like 36,000 kilograms. And this actually means this kind of increase in the burden of pain in the country. Because of this, in the early days of our work in the 1990s in Calicut, there were frequent interruptions of morphine supply. I clearly remember one man who used to come from a town about 2 hours away every 2 weeks to collect morphine. And he came, the morphine was not there. We did not know when it would come. So we would say, we don't know, but we hope it will come in a week. So we would give him instead very inadequate substitutes. He came twice. The second time, morphine was not available. And he said, I'll come again on Wednesday. I have noted a convenient tree outside your clinic. I will keep a nylon rope in my pocket. If on that day morphine is still not available, I do not want to go on living. I am going to hang myself from that tree. By some divine intervention, by Wednesday, morphine had come. But seeing patient after patient who had been in pain and had their pain relieved by morphine, and then having to say, sorry, we cannot give you morphine, that was very, very painful, very difficult time.
Non-cooperation with evil is as much a duty as cooperation with good.
Morning, ladies and gentlemen. Let us take the last quarter of a century and all the educational efforts that have gone into developing countries. Let us also see what impact it has had on access to pain relief in the developing world. The effort has been so much. There has been an impact, no doubt, but considering the whole of the pain burden in the developing world, we will have to admit that the impact has been very, very small. Let us see what more we can do. I am quite convinced that no country can really grow alone. We are talking about growth, maybe growth in the area of compassion and rational medical practice, but this growth has to be global. So when we work with international agencies, say with pain and policy studies group, without them we couldn't have grown. And also some working group meeting happens. And the presence of a few people like me is important because the experts may miss some ground realities. We have to tailor it to suit our realities. Can we get interested trainees from developing countries, bring them to countries where there is good integration of pain management into healthcare? Can we train them? There are problems. For one thing, much of what I come to your country and learn might be irrelevant in my country because of the cultural realities, because of the economic realities. I strongly believe that basic pain education to a trainee has to happen in the locality, within the region, so that unnecessary cost can be avoided and the cultural reality will be taken into consideration. And a training in the West in a good center should be for the selected few for capacity building for them. It has been a lot of travel, like in the last 2 months. Nationally, I have been to several times to Delhi. I have been to the Northeast, Tripura, and Mizoram, Kolkata. I mean, on the international level, again in the last 2 months, I have been to USA, Mexico, Switzerland, Uganda. So it's a lot of travel. I think it's right from the time I came into palliative care. I mean, starting with my training in Oxford. Then we started working with the government of India for changing the law, which meant a lot of travel to Delhi. And also, from that time, I started getting invited for international meetings and conferences, working group meetings, congresses.
The difference between what we do and what we're capable of doing would suffice to solve most of the world's problems.
Delhi is a seat of power in the country. And when I think of Delhi, the first thought that comes into my mind is, God, how long hours have I spent in the corridors of various government offices? Bureaucracy in India, it is causing a lot of pain to our fellow human beings, and most of it because of poor understanding, because of misconceptions. What I learned when I tried to procure the license so that people could access morphine was that the officials were viewing me with suspicion. I was sometimes very rudely treated, but we had those people rolling in pain. So this is North Block on the right side, where we did all the work. Many non-government organizations do not enjoy working with the government. It may not be fun, but it is very essential. The 1985 Narcotic Drugs and Psychotropic Substances Act of India was a huge barrier to access to pain relief in the country. This had to change. Thankfully, David Joranson of a Pain and Policy Studies Group in Madison, Wisconsin, he helped us analyzing policy. And we worked together in that North Block. It took many years, a quarter of a century. But this work paid its dividends when the draft amendment went up to the Indian Parliament in the year 2012. At every session of the Parliament, there would be more than 120 items of legislation waiting there. Now, out of them, only some 10 to 15 ever get passed. And that's because the Parliament would be disrupted because of the political turmoil. It was very hard to get this one into the list of 10 or 15 among the 120. We repeatedly wrote to all the 500 plus parliamentarians in the country. We sent repeated emails to them. Activists in various parts of the country personally met as many parliamentarians as possible, briefed them of the situation, and we explained that while improving access for pain relief, the law also made provisions for prevention of abuse. These explanations and this advocacy was crucial. No, but unfortunately, during three sessions of the Parliament in 2013, it did not get taken up. It would be on the agenda most days, but in the afternoon, the Parliament disperses without action. And the risk was the government at that time would cease to exist in April 2014. And then the whole thing is cancelled. we would have to start all over again. All pending items in the legislation are cancelled. Fortunately, in 2014, there was an additional supplementary session of the parliament. We took help from numerous sources, and on the last but one day of parliament, the lower house, that's the Lok Sabha, passed it. The barrel was not won. There was only one more day. On that day, if the upper house, that is Rajya Sabha, doesn't pass it, it would be total failure. But at 5:30 p.m. on the last day of the parliament in February 2014, Rajya Sabha passed it. I was in my office in Trivandrum, and about 2 minutes after the event, one member of parliament with whom we were in touch sent me a text message. Your law has been passed. And that was a time of sheer joy. Now, that is a huge breakthrough. It is not as if the work is completed, because the changed law will now have to be implemented at the state level in 29 of India's states. India being a country with 1/6 of the world's population, you can understand it's a huge task, but there is no easy way. We will have to continue to work at it. So I have very fond memories of my time here. I also have not so pleasant memories there, but on the whole, it has been a very satisfying experience.
India is the best!
National pride, I think it is something that's essential for our existence. Who doesn't want to be proud of one's own country? We have so many good qualities. We have our nature, our beauty, the land. We have the character of the people who are always mostly compassionate, intrinsically. City life may have changed many, but basically you lend a hand to help somebody else. And we have Mahatma Gandhi, who is revered all over the world.
A man is the product of his thoughts. What he thinks, he becomes.
I did not grow up as a very brave boy. If I use an adjective, I would use I was very cowardly. I couldn't face the world. But the quality in him that appealed to me most, the qualities were honesty and courage. His kind of courage I have not read about or seen in anybody else. I don't think he was infallible or anything, but he certainly had the courage to stand by what he believed in, even when the whole of the rest of his entourage was against him. I admired him. That reading helped me. Yes. Our first 9 years were glorious years. It was a very satisfying time in the early days when it was a small group of people. But as we grew, as the requirements grew, as we needed more people, that pleasure of having a close family-like atmosphere was lost. I was no expert in management, and by the time I retired from government service formally in 2002, I decided to hand over the control to my successors, my colleagues there. I decided to concentrate more on the rest of the country. I came back to my hometown because in the meantime, the northern half of Kerala had developed a very strong network of palliative care programs, maybe around 100 by that time. Now we see that there is quite a bit of palliative care in Kerala, which is only 1% of the geographical area of India. the 99%, which is 97% of the population, has very little palliative care. So in 2003, with a few of my colleagues, we formed the organization called Pallium India. But balancing work and family life is not easy for anyone who is a pioneer. People who are in a position of leadership anyway, very often feel the need to project an image of strength. They cannot very often afford to express vulnerability or weakness. This puts them in a position of loneliness because you are leading a group of people who need a shoulder to cry on sometimes. And sometimes you find that a leader does not find it easy to find a shoulder to cry on. So without support of families, it can be very, very hard. Personally, I have been lucky. It would have been very difficult for me to do this if I did not have a supportive family. That helped me to do what my heart wanted to do. So Pallium India's vision is to integrate palliative care into healthcare at a national level. We do several things to reach that goal, including advocacy with government and healthcare systems. We also try to improve access to palliative care education. We also try to catalyze the development of palliative care centers in various parts of the country. And the dots all indicate places that we have touched so far. So both working on the clinical side as well as on advocacy is an important part of our work. In addition to the advocacy that we do in Delhi with the central government.
My life is my message.
This is where we have set up the Trivandrum Institute of Palliative Sciences. We don't own the place. This is a private hospital which closed down a few years back, and we have rented most of the hospital. So we have to find this huge amount as a monthly rent, which has to come out of public donations. We have been doing this, moving from one place to another for a long time. I mean, over the last 10 years, we moved house 6 times. This is also where we have the training center and other associated facilities. See, this is where we have the outpatient clinic. Right at the moment, there are no patients here. The sign, listen, because we forget very often. We talk so much that we forget to listen. So the doctor and nurse are reminded, listen to the patient. They will tell you the story. Then you are able to help them so much better. Happy to introduce our pharmacy to you. The medicines are procured from dealers at the lowest possible cost with donated money. And the home visit team carries several bags with supplies, medicines, everything, so that the boot of the home visit vehicles themselves form mobile pharmacies. Fortunately, in Kerala, we have a manufacturer of low-cost morphine. 10 milligrams of morphine in Kerala costs about 1 rupee, which is less than 2 cents of American money. We buy them and give it free to patients because patients cannot go out and buy it from a pharmacy in Kerala. That's deliberately kept there to prevent abuse. Legally, pharmacies can apply for a license and sell it on prescription. But in practice, no pharmacy wants to do that. The profit margin is infinitesimally small and nobody wants to do the paperwork. We here choose to do that paperwork and take responsibility for stocking and dispensing. This is our halfway home for people with paralysis. In most countries, palliative care would not include paraplegics in their patients list. That's fine if they have another system for caring for them. But in developing countries, really there is nothing else. We certainly refuse not to treat them. And actually, by the World Health Organization definition, palliative care includes prevention of suffering also, usually ignored. But prevention of suffering is part of it. So the disease is not the criterion. The proximity to death is not the criterion. Some people may need palliative care for 35 years. That's fine.
Live as if you were to die tomorrow. Learn as if you were to live forever.
Based in the government medical college hospital, in the particular hospital there for women and children, we work with the Department of Pediatrics and the Department of Pediatric Neurology to conduct a palliative care service. This is meant for children without any restriction on disease. What palliative care teaches us is that human beings are more than containers of diseases, that our aim should be and has to be improvement in the quality of life, also not only the quantity of life. That means that it's important to prevent suffering in the context of palliative care or in the context of healthcare as a whole. It's important to prevent diseases. So our palliative care clinic is available for any child with a seriously life-limiting condition. We are part of the medical system in the country, and together we have the duty to take care that we do not inflict suffering and we actually try to improve the quality of life of our patients and families. One of our management modalities in palliative care, apart from treating pain and symptoms, is to make sure that children of families afflicted by disease do not drop out of school. We support their education. We have had a doctor qualifying from our list. We have several nurses and engineers who have been supported to complete their education. I believe that education is the key to improvement for India and many developing countries like India.
In a gentle way, you can shake the world.
ഇവിടെ വരും ഈ പിള്ളേരെയൊക്കെ കാണുമ്പോൾ ഓരോരുത്തർക്ക് പിന്നെ ഒരു മനസ്സ് മതി.
അപ്പോൾ അവർ മറ്റിടത്തോട്ട് പോയാൽ
എന്തെങ്കിലും ആ കൊച്ചിൻ്റെ കാര്യം അങ്ങനെ നമുക്ക് പോണ്ടാന്ന് പറഞ്ഞ് തടഞ്ഞു നിർത്താൻ നോക്കില്ല.
One of the ills of modern medical system is that it does not seem to understand what's its purpose, what's its goal. A 14th century aphorism said that a doctor's duty is to cure sometimes, to relieve often, and to comfort always. Unfortunately, all the effort is at curing. Diagnose, cure. If cure is not possible, keep on attacking the disease, even when cure is not possible. Palliative care in this context will be meaningless if it's only medicines. In this particular instance, the most important issue is the social issue. And if we are unable, there I'm not sure that we have done the best. I think there is more we can do, and we have to. This is not a routine situation. This is a special situation. If treatment is aimed at sustaining life of reasonable quality. That is great. But even when cure is totally impossible, even in a patient with advanced cancer or a person with stroke whose brain has been totally destroyed, shutting him up inside an intensive care unit, putting him in life support systems, putting in an endotracheal tube into his throat, connecting him into an artificial ventilator, and keeping him imprisoned inside the intensive care unit, possibly very cold, without a human touch, not able to see his relatives, not able to say a goodbye to his son or grandchild, or his father or mother. That is a real tragedy. Poor people whom we treat do not go through this, but everybody who has some money is threatened by this kind of cruel, inhumane way of over-medicalized death. Medicine has to refocus and concentrate on quality of life when cure or prolongation of life is no longer possible, and we need to allow people to remain connected to their environment and to their loved ones. Sometimes people ask me, how can you continue to do this job? Isn't it grim, suffering and death all around us? The person who asks doesn't really understand what it's all about. This is about joy. This is about laughter. This is about happiness. I still treasure the picture of one of my patients, a 4-year-old girl, kissing me on my cheek, and she would give me that kiss maybe several times a day because she had this agonizing pain. But once the pain is gone, all of a sudden she would sit up and smile and pretend that the pain did not exist, start playing. That's happiness. That's joy. I swear to fulfill, to the best of my ability and judgment, this covenant. The Hippocratic oath asked me to treat my patient with warmth, sympathy, and understanding. And when my turn comes to be a patient, I would very much like that warmth, the empathy, and the understanding. Now, I will have some expectations out of my treatment. It's almost inevitable that some of the expectation may be unrealistic. I may want a cure when cure is not possible. I will need help to come to terms, to bring my expectations down to reality. But then I want the physicians to improve the reality to as much as possible. And this marriage between the expectation and reality is essential for my welfare, for my quality of life. I will remember that there is art to medicine as well as science, and that warmth, sympathy, and understanding. The real problem is, just as I did a half-century back, today the medical student takes that oath but does not see it being practiced. This is so very important for you and I because we are all potential patients. And for us to get care with the art and science of it, with respect, with dignity, my physician needs to practice this. I will remember that I do not treat a fever charge, a cancerous growth, but a sick human being whose illness may... I believe that palliative care has given the medical student and the young doctor the opportunity to see this being practiced in full. We prevent suffering when we can, and we take away suffering when we can. And now that the World Health Assembly has finally in 2014 recommended that palliative care is to be integrated into healthcare as a whole, this becomes all the more important. If it is to be integrated, that integration has also to be demonstrated. And we will all then practice what we have taken the oath to do. Once we are able to practice it, we are able to make the Hippocratic oath come alive. It lives then. It doesn't live till then.
The filmmakers acknowledge and respect the tireless commitment of palliative care teams delivering ethical medicine across the globe, and express gratitude and respect for the timeless teachings and memory of Mahatma Gandhi. Please help us spread this message. Share this film. Book Dr. Rajagopal for a speaking engagement. Donate to the cause.